Welcome to Pediatric Case Review. Today's lecture covers craniosynostosis syndromes, focusing on clinical recognition, diagnostic approaches, and management strategies for practicing clinicians. This comprehensive review will enhance your ability to identify and manage these complex craniofacial conditions. Let's begin our educational journey through case-based questions and detailed explanations. A 4-month-old infant presents with a distinctive cloverleaf skull deformity. On examination, you notice broad thumbs and broad great toes, along with midface hypoplasia and pertussis. Which craniosynostosis syndrome is most likely? Option 1, Apert syndrome. Option 2, Crouzon syndrome. Option 3, Pfeiffer syndrome type 2. Option 4, Sather-Chatson syndrome. The correct answer is Pfeiffer syndrome type 2. The cloverleaf skull deformity, combined with broad thumbs and broad great toes, is pathognomonic for this condition. This represents the most severe form of Pfeiffer syndrome, caused by fibroblast growth factor receptor 2 gene mutations. These patients face significant challenges, including severe pertussis, and require intensive multidisciplinary management. A newborn presents with brachycephaly and pterocephaly. Hand examination reveals complete syndactyly involving digits 2, 3, and 4. Similar syndactyly patterns are observed in the feet. What specific hand deformity classification describes this finding? Option 1, simple syndactyly. Option 2, complex syndactyly with osseous fusion. Option 3, mitten hand or spade hand deformity. Option 4, polysyndactyly. The correct answer is mitten hand, also called spade hand deformity. This type 1 apert hand demonstrates complex syndactyly with osseous fusion of digits 2, 3, and 4. This finding occurs in virtually all patients with Apert syndrome and requires staged surgical reconstruction to improve hand function and appearance. A 6-month-old infant presents with a flat forehead and prominent eyes. The head shape shows brachycephaly. There are no limb abnormalities. The father has similar facial features. Which finding would confirm bilateral coronal synostosis? Option 1, metopic ridge palpable on examination. Option 2, harlequin eye sign on skull radiograph. Option 3, scaphocephaly head shape. Option 4, anterior fontanelle widely open. The correct answer is harlequin eye sign on skull radiograph. This finding demonstrates elevated lateral orbital rims caused by premature coronal suture fusion. The resulting brachycephaly, with shortened anteroposterior and widened transverse diameter, is characteristic. This represents the most common cranial suture involvement pattern in syndromic craniosynostosis and requires careful evaluation. A 3-year-old child presents with exorbitism and midface hypoplasia. Multiple suture synostosis is confirmed radiographically. Hand and foot examinations are completely normal. Developmental assessment shows age-appropriate intelligence. Which diagnosis is most consistent with this presentation? Option 1, Apert syndrome. Option 2, Crouzon syndrome. Option 3, Pfeiffer syndrome. Option 4, Carpenter syndrome. The correct answer is Crouzon syndrome. The absence of limb abnormalities distinguishes Crouzon from Apert and Pfeiffer syndromes. Patients typically have normal intelligence, which is an important positive prognostic factor. Crouzon syndrome represents the most common form of syndromic craniosynostosis, caused primarily by fibroblast growth factor receptor 2 mutations. A 2-year-old child with known Crouzon syndrome develops new symptoms, including morning headaches and projectile vomiting. Fundoscopic examination reveals papilledema. The child shows increasing irritability and lethargy. What is the most urgent next step? Option 1, schedule routine craniofacial surgery in 6 months. Option 2, increase analgesic medications for headaches. Option 3, obtain urgent neuroimaging and neurosurgical consultation. Option 4, arrange genetic counseling for family. The correct answer is obtain urgent neuroimaging and neurosurgical consultation. This child demonstrates the classic triad of raised intracranial pressure, morning headaches, vomiting, and papilledema. Delayed treatment risks permanent vision loss and brain damage. Urgent cranial vault decompression may be necessary. This represents a true neurosurgical emergency requiring immediate intervention. What is the primary molecular mechanism underlying most forms of syndromic craniosynostosis? This understanding is crucial for genetic counseling. Option 1, loss of function mutations in bone morphogenetic proteins. Option 2, gain of function mutations in fibroblast growth factor receptors. Option 3, chromosomal deletions affecting HOX genes. Option 4, mitochondrial DNA mutations affecting osteoblasts. The correct answer is gain of function mutations in fibroblast growth factor receptors. These mutations, primarily affecting fibroblast growth factor receptor 1, 2, and 3 cause enhanced osteoblast differentiation leading to premature suture fusion. This autosomal dominant inheritance pattern has important implications for genetic counseling and enables both prenatal diagnosis and predictive testing. An infant presents with an elongated skull shape called scaphocephaly. A prominent ridge is palpable along the sagittal midline. The biparietal diameter is measured as narrow. Which suture is prematurely fused? Option 1, bilateral coronal sutures. Option 2, metopic suture. Option 3, sagittal suture. Option 4, bilateral lambdoid sutures. The correct answer is sagittal suture. According to Virchow's law, growth is restricted perpendicular to the fused suture, causing compensatory growth parallel to the fusion. This creates scaphocephaly or dolichocephaly. While sagittal synostosis is the most common isolated craniosynostosis, it rarely occurs in syndromic forms of the condition. A 4-month-old infant has suspected craniosynostosis based on abnormal head shape and a palpable ridge. You need to confirm the diagnosis before surgical planning. What is the preferred initial imaging study? Option 1, plain skull radiographs in multiple views. Option 2, 3-dimensional computed tomography scan with reconstruction. Option 3, magnetic resonance imaging brain with and without contrast. Option 4, cranial ultrasound through fontanelle. The correct answer is 3-dimensional computed tomography scan with reconstruction. This represents the gold standard for definitive diagnosis, providing detailed suture anatomy and essential information for surgical planning. While radiation exposure is a consideration, low-dose protocols minimize risk. Magnetic resonance imaging plays an important complementary role in evaluating brain parenchyma and associated anomalies. A newborn has obvious Apert syndrome features on clinical examination. Family history reveals no previous affected individuals. The parents request genetic testing and counseling. What genetic test should be ordered first? Option 1, chromosomal microarray analysis. Option 2, whole exome sequencing. Option 3, targeted fibroblast growth factor receptor 2 gene sequencing. Option 4, parental carrier testing. The correct answer is targeted fibroblast growth factor receptor 2 gene sequencing. Over 98% of Apert syndrome cases result from fibroblast growth factor receptor 2 mutations, with 2 specific mutations accounting for most cases. This targeted approach is cost-effective and provides valuable information for genetic counseling regarding recurrence risk in future pregnancies. A 5-year-old child with Craniosynostosis syndrome complains of progressive vision deterioration over 2 months. Examination reveals severe ptosis and exposure keratopathy. The child has had 2 cranial surgeries in infancy. What intervention is most urgently needed? Option 1, prescribe protective eyeglasses and lubricating drops. Option 2, refer for mid-face advancement surgery evaluation. Option 3, initiate oral corticosteroid therapy. Option 4, arrange regular ophthalmology follow-up in 3 months. The correct answer is refer for mid-face advancement surgery evaluation. Severe mid-face hypoplasia causes dangerous globe exposure that medical management cannot adequately address. Progressive vision loss demands urgent surgical intervention through Lufort-free osteotomy or monoblock advancement procedures. Delayed treatment risks permanent corneal scarring and blindness, making this a true ophthalmologic emergency. A 6-month-old infant with Apert syndrome currently shows no signs of raised intracranial pressure. The parents inquire about optimal surgical timing. What is the ideal age for initial cranial vault surgery? Option 1, within first 3 months of life. Option 2, between 6 to 12 months of age. Option 3, wait until 2 to 3 years of age. Option 4, delay until after 5 years when skull growth slows. The correct answer is between 6 to 12 months of age. This timing balances surgical safety with effectiveness, capitalizing on bone malleability while minimizing anesthesia risks. Rapid brain growth during this period benefits from timely cranial vault expansion. However, earlier intervention becomes necessary if raised intracranial pressure develops. Additional stage procedures typically follow. Which specialists are essential for comprehensive craniosynostosis syndrome care when establishing a care team for a newly diagnosed patient? Option 1, neurosurgeon and plastic surgeon only. Option 2, neurosurgeon, geneticist, and ophthalmologist. Option 3, neurosurgeon, craniofacial surgeon, geneticist, ophthalmologist, and developmental specialist. Option 4, pediatrician and neurosurgeon only. The correct answer requires a full multidisciplinary team including neurosurgeon, craniofacial surgeon, geneticist, ophthalmologist, and developmental specialist. Additional team members include orthodontists, ear, nose, throat specialists, and speech therapists. Coordinated care through dedicated craniofacial centers provides optimal outcomes. These patients require lifelong multidisciplinary management with multiple staged interventions throughout childhood and adolescence. A newborn with Pfeiffer syndrome type 2 experiences difficulty establishing adequate ventilation in the delivery room. Examination reveals severe midface hypoplasia and glossoptosis. What is the most appropriate immediate airway management? Option 1. Continue standard face mask ventilation attempts. Option 2. Nasopharyngeal airway placement and prone positioning. Option 3. Immediate tracheostomy in delivery room. Option 4. Elective intubation with standard laryngoscope. The correct answer is nasopharyngeal airway placement and prone positioning. Severe midface hypoplasia causes upper airway obstruction that initial non-invasive maneuvers can often manage effectively. Nasopharyngeal airways bypass pharyngeal obstruction, while prone positioning reduces tongue-based obstruction. However, preparation for difficult intubation or potential tracheostomy remains essential in severe cases. Which factor most strongly predicts normal intelligence in syndromic craniosynostosis when counseling families about developmental prognosis? Option 1. Number of sutures involved. Option 2. Timing of initial surgical intervention. Option 3. Specific genetic syndrome diagnosis. Option 4. Severity of midface hypoplasia. The correct answer is specific genetic syndrome diagnosis. Prezone syndrome patients usually demonstrate normal intelligence with the best developmental prognosis. Apert syndrome shows variable outcomes with higher developmental delay risk. Pfeiffer syndrome types 2 and 3 carry poor prognosis with severe impairment. Timely surgical intervention prevents intracranial pressure-related damage, while early intervention services benefit all patients. A 3-year-old child with Prezone syndrome develops new symptoms, including swallowing difficulties and worsening sleep apnea. Neurological examination reveals upper extremity weakness. Magnetic resonance imaging shows cerebellar tonsillar herniation below the foramen magnum. What is the diagnosis and appropriate management? Option 1. Gastroesophageal reflux. Start proton pump inhibitors. Option 2. Chiari-1 malformation. Consider posterior fossa decompression. Option 3. Brainstem tumor. Urgent oncology referral. Option 4. Normal variant. Reassurance and observation. The correct answer is Chiari-1 malformation requiring consideration of posterior fossa decompression. This complication occurs in up to 70% of patients with multi-suture craniosynostosis due to small posterior fossa volume. Symptomatic patients require posterior fossa decompression surgery. Regular screening with magnetic resonance imaging is recommended for all syndromic craniosynostosis patients. Why is audiology screening particularly important in craniosynostosis syndromes when planning comprehensive care? Option 1. Skull surgery directly damages auditory nerves. Option 2. Middle ear anomalies and chronic effusions are common. Option 3. Medications used cause ototoxicity. Option 4. It is not particularly important. Standard newborn screening is sufficient. The correct answer is middle ear anomalies and chronic effusions are common. Up to 55% of patients develop conductive hearing loss due to eustachian tube dysfunction and stenotic ear canals related to midface hypoplasia. This significantly impacts speech and language development. Regular audiometry screening, starting in infancy, and ear-nose-throat specialist involvement are essential components of comprehensive care. An 18-month-old child with Apert syndrome had cranial vault surgery 6 months ago. Now the child presents with persistent vomiting, lethargy, and increasing head circumference. Computed tomography imaging shows enlarged ventricles. What complication has developed? Option 1. Surgical site infection requiring antibiotics. Option 2. Post-operative hydrocephalus requiring shunt. Option 3. Normal post-operative changes. Option 4. Syndrome progression requiring revision surgery. The correct answer is post-operative hydrocephalus requiring shunt placement. This complication develops in 10 to 15% of syndromic craniosynostosis patients, particularly those with multiple suture involvement or Chiari malformation. Treatment typically requires ventriculoperitoneal shunt placement. With appropriate management, prognosis is generally favorable, though these patients require careful long-term monitoring. A 4-year-old child with Apert syndrome has severe obstructive sleep apnea documented on sleep study. Parents report loud snoring and restless sleep. Previous adenotonsillectomy did not resolve symptoms. What is the most appropriate next management? Option 1. Prescribe nasal steroids and antihistamines. Option 2. Continuous positive airway pressure therapy. Option 3. Repeat adenotonsillectomy procedure. Option 4. Reassurance that symptoms will improve with age. The correct answer is continuous positive airway pressure therapy. Over 75% of patients develop sleep-disordered breathing due to midface hypoplasia and airway narrowing. When adenotonsillectomy proves insufficient, continuous positive airway pressure provides effective management. Definitive treatment through midface advancement surgery addresses the underlying anatomic cause. Untreated sleep apnea risks serious complications, including failure to thrive. Which dental complication is most common in Apert syndrome when planning orthodontic intervention timing? Option 1, tooth agenesis or missing teeth. Option 2, enamel hypoplasia. Option 3, maxillary hypoplasia with severe malocclusion. Option 4, supernumerary teeth. The correct answer is maxillary hypoplasia with severe malocclusion. The underdeveloped maxilla creates class-free malocclusion requiring coordinated orthodontic surgical management. Treatment involves orthodontics during growth periods with possible Leufort advancement surgery in adolescence. An orthodontist represents an integral craniofacial team member since dental complications significantly affect feeding, speech, appearance, and self-esteem. Thank you for joining this comprehensive review of craniosynostosis syndromes. Remember that early recognition, multidisciplinary care, and vigilant monitoring optimize outcomes for these complex patients. Please subscribe to Pediatric Case Review for more informative educational content. If you have questions or interesting cases to discuss, please share in the comments below. Thank you.